Welcome back, everyone. Hope you are all having a good Thursday. Joining me are my good colleague from the NTG, Dr. Kathy Bishop, Phyllis Amaral from OPICA, and Monica Moore, also from OPICA, who is our presenter today. I'm going to go through just a few housekeeping things with you, but before I do, I want to put up the pretest. Those of you that have attended before, whoops, sorry, that got to the wrong slide here for some reason. There we go. We're going to put up the pretest. Those of you that have been on here before know how that works. So I'm going to put it up and leave it for a few minutes while I go over a few housekeeping things. And so here it comes. You should see that on your screen momentarily. If you don't, somebody tell me in the chat, but it should be up there. So welcome back. We got a great presentation for you today. We will, as always, mute everyone by default, but if you have a question, we will unmute you if we need additional information, or if you have more information that can really be shared in the question and answer box. And to that point, if you have a question about anything our presenter is talking about today, if she says something that reminds you perhaps of a situation that you've been involved with, you want to bring up or ask questions about, or if you're not clear about something, please put your questions in the Q&A box. You don't need to wait until we announce a formal Q&A time. Go ahead and put them in the box as you think of them, and we'll be monitoring them on this end. And we will make sure that those questions get posed to our presenter before we end today. We may do them in the midst of her talk, or we may hold some for the end. But don't wait, put them in the Q&A box. There's also the chat box. We do ask that you reserve the chat box for any sort of technical questions that you may have. So technical questions go in the chat box, and questions about the content go in the Q&A box. We also have a couple of videos that are going to be shown today, so make sure that, I was going to say make sure you've got your volume up. If you didn't have your volume up, you wouldn't be hearing me talking at this point in time, but just trying to cover all my bases here. And so with that, I am going to leave the pretest up, but I am going to stop sharing my screen so that our presenter can get her slides up. The poll is still up there and still is going to be up there for a few minutes. And I am going to hand this over to Phyllis Amaral from OPICA, who is going to introduce herself for those who are newcomers, and also introduce Monica, our presenter today. So take it away, Phyllis.
Thank you, Catherine. Good morning or good afternoon, everyone. Welcome to the 7th webinar in the series sponsored by OPICA, Adult Day Program and Counseling Center in Los Angeles, California, in association with the NTG, who has provided tremendous content and technical assistance for the webinar. I want to also acknowledge the Administration for Community Living for their funding and their support of the webinar. And I'd like to take just a brief minute to introduce a terrific speaker and a good friend, Monica Moore, also associated with, among other places, OPICA Adult Day Program and Counseling Center in Los Angeles. Monica has been in the field for over 20 years. She's a passionate advocate for adults with dementia. And she has functioned as a community educator and works with supporting caregivers for individuals living with dementia. I can't say enough about her. She's got tremendous experience, a tremendous warmth. She's incredibly respected and in the city of Los Angeles. And I turn the presentation over to her to talk a little bit about, or a lot about, behavior management, dementia, and IDD. Thanks, Monica.
And Monica, I'm going to let you introduce yourself, and then once you're done introducing yourself, I'm going to close the poll once you get started with your slides.
Perfect. Sounds good. Thank you, Phyllis. Very kind. It is a great pleasure to be able to be here. So thank you very much to Catherine and to Kathy and to NTG and to ACL for allowing me to be here. So as Phyllis said, my name is Monica Moore. It is a pleasure to be able to work with OPICA on helping with their family caregiver trainings, helping with general community education, and just sort of raising awareness as to the world of dementia and the importance of education. It's really one of the passions that I have, is just letting people know what Alzheimer's is, what dementia is, how to reduce stigma, and also how can people live a brain healthy lifestyle, and we can hopefully reduce numbers and incidences of dementia. So thank you again for being here. I appreciate your time. Catherine, I am ready to go when you are ready. And I'm just going to start and dive right in here.
You're good. You're good to go.
Awesome. Great. Thank you. And also, again, as Catherine mentioned, please, if you have questions, put them in the chat. I keep the chat open, or not the chat, sorry, the Q&A. I keep the Q&A open during our presentations so that if something comes up, I can try to address it at that moment. So please feel free to put your questions in the Q&A, and I'll try to address them during the presentation. If not, we'll get to them at the very end. So today our objectives are to discuss behaviors associated with mid-stage dementia, to understand behaviors that may increase as dementia progresses, and also to understand possible approaches to dementia-capable behavior management. This is a really big piece, and really where I hope that you'll come out of this presentation with some solid information that you will really be able to use in your daily life, and that will really be practical for you. So the first thing is always just like to get this information at the front so we know what we're talking about. So we're all on the same page here. So these first few slides are directly from the Alzheimer's Association, talking about the number and the ages of people with Alzheimer's disease and the prevalence that exists. As we see, so this is current as of last year from their Facts and Figures report. The 2025 version has yet to come out. But we realize currently 6.9 million Americans have Alzheimer's related dementia. So it could be Alzheimer's dementia caused by Alzheimer's disease is what we're really focusing on in this population. Also in this is probably some undiagnosed dementia, and other areas where it's more questionable or probable dementia. But we're looking at these numbers where it's currently 26.4% of our population, really right there with dementia. In the next 10 years, we see how that's going to increase to 38.6. And then people who are 85 plus years, we see how those numbers are going to increase as well. So just looking at the bulk of our population, our country is aging faster. It's actually one of the fastest growing age groups that we have. So the 65 plus. So we see how Alzheimer's disease is really going to be impacting our communities and all of our professional work lives. So here we are looking at the greater trajectory of Alzheimer's in the United States. Again, this goes back to the statement I just made regarding the fastest growing age group in our population is this 85 plus. So when I got my master's degree about 20 years ago, this was a big focus, and we see now how it's even more so because we are able to live longer, right? People are surviving strokes, they're surviving heart attacks, we're able to cure cancer in many people. So these ailments that once caused an early death are now we're curing them, we're helping people live longer lives. But what we need to look at is how can we live longer, healthier lives without Alzheimer's disease being a part of those lives and of our population. So now looking at this world of Alzheimer's in terms of what is it exactly? What do we consider Alzheimer's disease to be? So this is, again, from the Alzheimer's Association, looking at their greater continuum. So as Phyllis mentioned, I work with OPICA, but also some of the other work that I do is I'll work with the UCLA Alzheimer's Research Center. So I work with a lot of doctors who are diagnosing people with Alzheimer's disease. People are coming in for their evaluations. And we look at this continuum here where at this first part is the preclinical area. So this is essentially where hopefully we all are at, where we do not have symptoms of Alzheimer's disease. But maybe the biological changes are starting to occur. And most likely they are. Researchers have seen that people who go on to develop Alzheimer's disease actually develop these biological symptoms. The amyloid plaque and the neurofibrillary tangles, or the tau, starts to develop 20, 30 years before any symptoms of the disease. So if we want to really change the course of the disease, this is where we need to start doing research, but that's another subject. So we have our preclinical Alzheimer's disease. And then the next phase is this mild cognitive impairment due to Alzheimer's disease. So this is when there are starting to be some symptoms, but they're not going to really impact a person's everyday activity. They might impact, things around the house. People in your very close inner circle may see these changes, but anyone outside of that inner circle most likely will not. Then it goes on to dementia due to Alzheimer's disease. And again, as you hopefully should know by since I am the 7th of these presentations, that dementia is a word that describes symptoms, and there's lots of causes of dementia. But this is when this dementia, this memory loss, forgetfulness, confusion to time and place, disorientation, is caused by Alzheimer's disease, but it's mild. So where symptoms are interfering with some daily activities, some day-to-day tasks probably need more Post-it notes and reminders on the phone. Definitely need more cueing and assistance from your loved ones, but still people are able to be fairly independent. And then the bulk of today's presentation is going to talk about this section right here: dementia due to Alzheimer's disease in the moderate stages. So this is really where a person's many everyday activities are starting to have problems. The disease, the symptoms are interfering with this part of their lives, and their ability to, be truly independent. And then there is dementia due to Alzheimer's, which is more severe. We're not going to touch on this area. It's just where most aspects of a person's life are impacted by the symptoms of the disease. Oops. So now looking at the stages, this is again is an image from the Alzheimer's Association. So this, if you're looking at the screen here, this little blue part that is on it'll be on all of the images here. These are the amyloid plaques and the neurofibrillary tangles, also known as tau. This is where Alzheimer's disease begins. So these plaques and these tangles were first discovered back in 1906 by Dr. Alzheimer. And these are the true hallmarks of the disease. To have Alzheimer's disease, you must have these plaques and the tangles. If you have some clinical symptoms but don't have these plaques and tangles, you don't have Alzheimer's disease. You have another form of dementia. So these plaques and tangles are often found first in the hippocampus, which is the part of the brain that is responsible for turning short-term memories into long-term memories. So really this crucial piece of our brains for us to be able to function. Everything needs to go in there before we can remember it, before we can do anything about it. It's a crucial part of the brain for our function. So the plaques and the tangles start to develop in the hippocampi. This early stage lasts for about 2 to 4 years. This is where people are having more difficulty with multi-step tasks, trouble recalling current or maybe historical events, and they start to withdraw a little bit more. That's something we're going to talk about a little bit more as well. In the mid stages, you see how these the amyloid plaques and tangles are starting to spread more to the temporal region of the brain, the parietal region of the brain. So we see how this is now this mid-stage 2 to 10 years. And these are vast estimations. I have known people who have, from the time of diagnosis to death, may have been 4 or 5 years. I know somebody currently who's caring for her husband, who he's probably on about year 16. So obviously these are vast differences. And this is general population that I'm speaking of right now in terms of these age, this time frame. People with IDD, it's going to be different because they develop this disease earlier. So people in the mid stages last again about 2 to 10 years. This is really where that assisted care needs. This is when someone will most likely be in a day program. In-home help will start to come in, maybe placement, institutionalization, really where people need a lot more assistance. There are going to be more behavior changes. Again, the bulk of today is this mid-stage area. And then in the late stages, again, this lasts roughly 1 to 3 years. This is when a person needs help with all of their IDLs and ADLs. They need help with pretty much everything of their life. They're having a hard time recognizing loved ones, hard time communicating, hard time walking, etc. So really seeing 24-hour hands-on care required in this late stage of the disease. So how does dementia in a general population differ than dementia in the IDD community? So the one thing that really we have seen is that there is an earlier age of onset. So the average age of a person with Alzheimer's disease in the general community is probably in the 70s. Depends. There's not a specific age, but about in the 70s is when there's usually more diagnoses that occurs. In the IDD community, it's earlier. It's in people in their 50s, people in their 60s who are developing this disease. People with Down syndrome are the ones who are most likely to develop dementia. And 30% of individuals in their 50s develop dementia in the Down syndrome community. And 50% of people in their 60s. So you see these numbers are so much greater, specifically in this population. It is an area where there's lots of research. There needs to be more, but there is research that is happening as to why. What exactly are the connections? What are the risks? And are there any ways to change those risk factors? The one thing that's really fascinating that I always find in this world of Alzheimer's disease is how these plaques and these tangles, they can be present in an autopsy, even if a person doesn't have what we call clinical symptoms, which is fascinating, right? You see a brain that could be riddled with these plaques and these tangles, but there's really no clinical symptoms of it. But in the IDD community, especially focusing on the Down syndrome population, these plaques and these tangles are starting to show up in the 40s of people who have passed and they did an autopsy and looked at that. It's like, well, now why? So right there, you're seeing how the biological changes of this disease is happening before the clinical symptoms. So this is that prime example of what I talked about earlier with the continuum slide. So, there are people with other developmental disabilities who also develop dementia, but especially in the Down syndrome community, dementia is at a much higher rate. So how does the disease progress with people in the IDD community? There are more behavioral changes, and this is an area and sometimes it's hard to tell because people, as you all know, that everyone has their own unique personality anyways. They all have their own strengths and weaknesses anyway. Depends upon what is their developmental disability, what has their life been, how have they been raised or educated, all of these types of things. These all make a big difference in a person's ability to cope. Also in what we call sort of a cognitive buffer that people have. So looking at these changes is very it's sort of hard to really determine what will be the exact way that a person with IDD will develop dementia. But we look at some of these things where they may have more of an indifference, more trouble learning. Again, changing from what their normal is. And that is one of the keys too. It's what's their normal. Not comparing it to me, not comparing them to you, but with their normal and where are the changes that exist there. So troubles with judgment, maybe they've always had a poor memory, but now you're really seeing that this memory is getting worse and it continues to get worse. So for example, if a person never remembered that their birthday, well, now the fact that they don't remember their birthday, that's not unusual, right? So that's not, oh, they have dementia. That's just who they are. So we look in a general population that might be a huge sign of dementia, but we see how it's going to be different based upon who the populations are. Also, a person with IDD will often begin a day program at what may be perceived as a later stage of dementia, but in reality, it's not. It's just their baseline is different than, let's say, somebody who was a UCLA physics professor's baseline. So it might be observed. We may have our prejudices and thinking, oh, they're probably further along, but in reality, they're actually not. If this does not make sense, if anything doesn't make sense, put it in the Q&A. So if we were all together, I'd be asking you to raise your hands, but please, if you have questions, Q&A, so that we can also have a dialogue. I want to make sure that everything is clear for all of you who are spending your time here today. So make sure that you are getting what you want out of this. So now looking at the moderate stage of dementia in all populations, this really is your longest stage. Sometimes people say, the beginning stages sometimes are the hardest because this is just when people are grappling, trying to figure out what is this, what's going on, what do we do, how do we change our life, what do we need? The moderate stage is the longest, and sometimes it's really when people start to get into like a rhythm and a routine. You understand that cognitive losses are going to be greater and they're going to continue. And so it's realizing that there is that one piece for the families that they need to be mindful of and be aware of. But when we're looking at the symptoms that occur more in this moderate stage, it's where there's going to be more forgetful of recent events. You could talk to somebody in the moderate stage of dementia. Let's say, for example, perfect topical example for right now, you talk to someone who, let's say, was a very devout Catholic, and you say, oh my gosh, well, Pope Francis's funeral is on Saturday, and they're going to say, he died? You're like, well, yeah, we've been talking about it for the past 4 days, but that's information that normal, healthy them would be right there, right on, hold on to it, but now they're not able to put all these pieces together and even to be able to recall that this event happened. So they're going to be more forgetful of events, their own personal history as well. During the moderate stage is sometimes where we hear of people who will confuse children for grandchildren or grandchildren for children because they shift where they perceive things. So if they look at themselves in the mirror, they're like, who's that old lady? Because it can't be me, because I'm not an 80-year-old old lady. I'm a 60-year-old woman. Because the way that they perceive themselves changes. And also the way they perceive all that is around them also changes. Looking at this, there will be more moodiness, more withdrawn, especially in socially or mentally challenging situations. And we'll talk about some of this a little bit later. There's also going to be a change in the sleep pattern. What we call a day-night reversal happens as well, where a person might have, okay, great. Okay, sorry, I just pulled up the Q&A. There we go. It was missing for me for a minute. More of a day-night reversal, where a person is sleeping more during the day. Why, right? We need to figure out the why. We want to get to the base of it. How can we intervene and how can we help sort of shift that back? There's a major behavior called sundowning. We'll talk about a little bit more as well, where it's really confusion with time and place with the sun. This always happens, and it's always so much worse whenever we change times. We all struggle with time change. Imagine a person with dementia, how they're going to struggle with time change, where you're starting to get irritated and agitated. And it's how do we intervene? How can we change this so it doesn't continue to happen? Because it's not something that, well, it's just Alzheimer's. This is what you're going to have to deal with. That's not it at all. It's a behavior that has a meaning, and we need to get to the root cause of it. Also, in moderate stage dementia, there's a tendency to wander and become lost. There is bowel and bladder incontinence that begins. Suspicion and delusions, so much. I lead support groups, and a few weeks ago, this woman, she was new to the group, and she was saying, my husband thinks I'm having an affair with our grandson. And she's like, she can't get him to realize that there's no way that would happen, and that it's not happening, but he believes this, and he believes it so strongly. And so how do you work with these behaviors? What do you do? Also, there's more compulsive, repetitive behavior that happens as well. So again, another image here. I like images. We see signs of mid-stage dementia. People will often ask, well, what stage is my loved one in? I was talking to some of the neurologists that I work with at UCLA, and I said, how do you stage a person with dementia? And they said, well, early, mid, late, moderate, or not quite that, moderate, late. They're not doing numbers, because a number system is sort of arbitrary. So looking at these images, looking at these statements of saying, this is roughly when a person is mid-stage dementia. Call it stage 3B, whatever, it doesn't matter. This is the stuff that matters. I say focus on what a person can do, not so much about the losses that they have experienced, but what can they do? So interventions, what are we going to do about these? All right, so we have lots of different intervention approaches. All of you here, if you're working in a day program, put on a detective hat, because this is what you're going to need. It's going to be one of those things that is so crucial for you in your everyday activities, and to make these things a success. Families send their loved ones to day programs so they're safe, so they're engaged. So this is your job now, is to figure out, how do we do this? So one of the things that we talk about in my meetings earlier with Kathy and Phyllis, and talking about prepping for this presentation, is especially thinking to people with IDD that may have a harder time processing the emotions that they are feeling, even if they are the emotions of aggravation or overstimulation. So making sure that there is a small room at the day center, even if it has to be somebody's office, where a person can go and they can calm down a little bit. There is a recliner in there. You see the recliners. OPICA has these great recliners and these great blankets, and ways where you can help make a person feel safe. Because isn't it deep down what we all want? We all want to feel safe. We all want to feel secure and to know that we are okay. So how do we express these feelings to a person at your day program? So also looking at giving people time to warm up. Sometimes if you can come right into a day program and all of a sudden it's, music time, that could be really overstimulating. So is there a way where someone can come maybe through a back door, have a few minutes, change scenery, change the environment, and then from there, they start to hear the music, yet it's not right in their face yet. And then they're able to come in. So finding these ways to sort of soft land them I guess, a bit into a day program, into an activity. There's lots of people, maybe someone isn't social, and this is what the family needs, and they need them here. So how can we work with the families? Looking at the important aspect of always being present. Creating an environment that maybe it's more sensory stimulation with senses, and the sense of touch. If you really think about it, lots of people aren't touched much. This was always one of my things during COVID, during the lockdown, which I said, like, but people aren't hugging. People aren't getting the sense of touch that we as humans crave and desire for our daily life. So finding these ways that you are able to provide that to a person. And we look at these last three bullet points on this slide, talk about redirection, understanding that all behaviors have meaning. So don't dismiss people, talk to them, listen to them. And if you need to, do what we call therapeutic fibs. In the dementia world, this is something that we rely upon, and we tell families, you got to get good at this. Because what if they're coming to you and they're saying, I'm late for school? They're 85 years old. They're not late for school. So how do you, you don't want to tell them that, because then that would wreck them. They say, oh, I need to get home. My mom's waiting for me. Well, their mom passed away 10, 15 years ago. So we come up with these little therapeutic fibs, white lies, fiblets, whatever, these little phrases that do help. I know that lots of people in the IDD community have always been sort of told to not do therapeutic fibs, like reality. We need to help orient them, reality orientation. But in the dementia world, we believe in therapeutic fibs because they help make it kinder and easier to a person. There's a lot that they might be grappling with, and this is a way to, again, soft land them into a day program, and to also help with any sort of increased agitation, increased moods, and other struggles that might be happening. So looking here at this preference-based model of care, lots of places say that we provide person-centered care. Big, like, buzzwords, right? Person-centered care. But really, how person-centered is lots of the care that is there? If you have 40 people, how much is it truly person-centered for each one? So this is an image here. Let me move my little Q&A. From Heitzma, created this preference-based models of care. Looking at, we all have our basic needs, right? Our needs and our values, but they all play a part in our preferences. So we want to be able to have the needs addressed. That is always, I think, first and foremost. Needs is required. Does someone have to go to the bathroom? Needs. Does someone feel scared? Again, a need. It's not a preference. And so we want to be able to find realize what is desired, but also at the same time, know what is undesired. Those are both very important. We want the needs to be first and then preferences. Then that'll help us meet the goals. So understanding that maybe we have to, again, switch the script a bit on the way we think about things, and really hone down and focus on the individual care that we are providing, and how are we able to help support the needs of participants in programs. I just muted myself. My apologies there. Okay. So this theory of compassionate communication is something I think really is so important with the dementia world, the IDD world, understanding their world's probably really confusing. Their world doesn't make sense. So we need to provide them an environment that does make sense, and an environment that is understanding to them. So we need to show patience. We need to be empathetic to them. We don't need to feel bad for them. No one wants pity, but we want we want the empathy. And constant and open communication is so important, where you're saying, okay, Mary, we're going to do this now. And now we're going to do this. And now we're going to do this, as opposed to, okay, Mary, we're over here now. They can't follow that. We can, we understand the logical steps. They do not have the capacity. And they're not being stubborn, and they're not being bullheaded, and they're not doing this to bother you. They are doing this because they all have a neurodegenerative disease that is impacting their ability to really have understand the world around them, and that is impacting their cognition. That's why I use the word cognition. I know it's a bigger word, as opposed to just focusing on memory, because it's not just memory. It's all of these other pieces that play a part. So it's the greater world of cognition. So when we are practicing compassionate communication, we want to look at the observations. We want to see what is around. We want to see from their eyes as well. What are they seeing that might be impacting their mood, their behavior? We also want to look at their feelings, not just what someone is thinking, but how is someone feeling? And these are hard. These aren't easy. So I'm not saying, well, you should be able to figure this out and move on your way. These are hard. So, but it's your goal as a professional to find the way to do this, to find what are their needs. Again, not preferences, but their needs. They may, also looking at requests, and we're asking these things of the person, realizing that their world has changed beyond their grasp. They don't understand how these changes have occurred, or that they even have occurred. So we are the ones who are now in charge of assessing and providing this safety, this comfort, and an understanding in the way that we communicate. Okay, there was a question that was just put in the Q&A, asking about what would be ideal recommendations for a day program for aging adults with IDD and dementia. I'm not going to answer that question. I will see if maybe Phyllis would be able to answer that, or maybe Kathy or Catherine could answer that one. That is not my area. And also, I know it always depends upon states and rules and regulations. So I will allow someone else to probably give you a better answer for that, or maybe point you in the right direction as to where you can find a better answer for that. I do see the question about wandering. Hold on to that. I'll get to that a little bit later. And then the first one, we'll circle back to that at the very end. So I do see your comments in the Q&A. So I just want to let you know that too.
Okay.
So
Did you want me to give a little answer, Monica, real quickly?
Yes, please. Thank you.
It is state by state and regulation of what the staffing ratio should be. And so always work with the IDD organization, who are the experts in this area. You can tell by regulation. It also really should be individualized based on the degree of care needed and support needed. Should be something that you work with the local organization to help determine that degree. Do you have sufficient staffing for that? And may even want to work in partnership to help with staffing, especially at the time to help someone with IDD and dementia adjust into the program. And so there is no research on this. There are no exact answers. It's one by one. But the information that Monica is giving you is extremely helpful to help you start making decisions. And I would never recommend that you just decide we'll accept 5 people, especially if you've never had a person with IDD and dementia in your adult day program. Start one at a time and start building a good relationship with the local organizations that can help you with the answers for that individual.
Great. Thank you so much, Kathy. I appreciate you stepping in there and chiming in. Thank you so much. So I hope that answered your question, Miss Anonymous attendee. So next thing we want to transition over to here is, again, talk about this person-centered care. So looking at this is like, why is this important? You know, we need to be able to bring people back from frustration, because it's going to happen. Again, their world is confusing. Their world is uncertain. So if there's really person-centered care where we are focusing upon individuals and their needs, what works? You know, we want to provide this feeling of importance, validation. Again, back to what I said, and I always continue to use this word, is safety. What do people want to be? They want to be safe, right? We also want to know that their feelings are validated. They could be sad and they could be there and they could be crying and everyone else is happy. And you're wondering, well, what's going on with Mary? Like, why is she crying? It doesn't really matter why she's crying. What matters is that she is. And so how can we help her acknowledge her feelings, understand that these feelings exist, and to be able to help maybe change the course of these feelings, especially if we see that they're bringing her distress and where she is not in a good, comfortable place. It really comes down to understanding the person. What are their likes and their dislikes? You know, if you have, I know there's lots of theories in the dementia world with like stuffed animals, where the soothing nature, there's these cats and these dogs that look lifelike. They look, you know, they even purr, they like make all these noises, they move, they breathe, that provide a person with comfort. But what if person doesn't like animals? We don't want to break out the cat and put the cat on their lap and think that, oh, this is going to cause them, so that like help them soothe them. It's not. It may have the opposite reaction. So really understanding the person and realizing not everyone is going to be the same. We're all unique. That's the beauty of humanity, right? So then what calms them? What does not? You know, also thinking too, music. What kind of music do people like? Everyone doesn't like the same music. Just because you may have all been born in the same few decades, everyone doesn't like the same music. So again, what really truly person-centered care, talking to families, talking to, let's say, if, one of your clients was an IDD, let's say if they were they lived in a home or another type of facility, ask them, ask the staff there, what works, what doesn't. No need to reinvent the wheel. This is just a matter of asking and really trying to find out ways to get to know your participants. So again, how to provide this person-centered care, talk about personal history. What did they like? What was their family like? Were they sports? Did they have a big family? Were they sort of ostracized? Were they very much a part of the family? Again, a person with IDD depends upon where they grew up and what the environment was and what the access to services was. So these all play a part in understanding a person and how you should really focus on their care. So let's shift a little bit here to talk about some risk factors that increase unwanted behaviors. Again, we're going to have all sorts of unwanted behaviors in the dementia world, just because, again, dementia is hard and dementia is confusing. So a new environment is going to definitely bring some unwanted behaviors, or at least it has the chance to. It may not. You might be lucky. But starting a new day program, starting a program, recently being released from the hospital. Say a person is moving from, let's say, their home, the home that they've always known. Maybe their family has just moved. So looking at these different factors. This next one of undiagnosed pain, I think, is so important, especially in IDD community, to really looking at, they may not be able to tell you that their tooth hurts. So what are they going to do? They're going to have more behaviors because of that toothache. And you think they're just being difficult that day. But what if there's an actual problem that is causing them to act that way? I know when I have a headache, I'm not a good person. But I can say, hey, family, I love you. I'm going to lay down. because I have a headache. A person in a day program who has dementia and IDD, they may not be able to do those things, most likely will not be able to. So you have to really learn body language, talk to families, figure out how can you assess for undiagnosed pain. Also looking at physical problems, shortness of breath, urinary tract infections, the number one cause for sudden changes in behaviors in older adults, and also medication side effects. And then boredom or loneliness. Just because there's a lot going on around you at a day center doesn't mean a person is actively engaged and really getting the most out of it. So I mentioned this very briefly earlier, sundowning, one of the different types of behaviors. We're going to just highlight on a few right now. This is, again, increased confusion that's experienced from dusk through nighttime, that time of the day where people are more disoriented. It can be displayed through all sorts of different behaviors. Usually it's more like anxiety, agitation. I had a family whose this woman's husband would open and close the blinds, open and close the blinds, open and close the blinds, just constantly. And to the point that he'd get so frustrated that he'd almost break the blinds. And so also at this point too, looking at just a greater world of hallucinations and disorientation. And it could be, caused by a mixed up body clock, more of a less need for sleep as people do experience. But we really say some of the ways that a person can engage and try to redirect is, looking at how much time has a person spent outside. We all need time outside every day, unless it's really storming or something like that, for the most part. So, but understanding the importance of getting out into the sunshine, having the sun hit a person's face, exercise, even if they don't want to. And when I say exercise, I don't mean, big dancing. I mean movement, walking, just getting at a slow pace. Those things are so important to help establish a person's rhythm of their body. Reducing screen time, reducing stimulation from TV and music. Again, even a day program, it's very stimulating. So how do you provide a peace of mind for the families? Because they're the ones that are going to be impacted by sundowning. You're not, because the people will be home by now. But how can you help set it up? Because during the day is what can impact the night. So how can you help set it up to be better for the families so that sundowning does not occur? Paranoia is an unfounded fear or suspicion. Fear that a person is being lied to, that they're being watched or followed. For example, let's say the person with dementia forgets where they put their money and they're blaming their family members because, well, you and I were the only two who live in the house. I didn't lose it. You stole it. Makes perfect sense. That is where their mind goes. It's not, where did I put it? Oh man, I must have, I can't find it. Nope. You stole it. So the feelings of helplessness really come about when a person can't understand what's happening, and when they can't find things. So being there, trying to help ease a person, trying to help calm them down as well. Hallucinations. So hallucinations, this is what I want to talk to about. And actually, I have a video for this one as well, which actually may just pop around to the video. Actually, I'm just going to pop to the video here. All right, so give me a quick second. So this is through the UCLA Alzheimer's and Dementia Care Program. They have these wonderful videos. So if you have give you the information for them, but they're wonderful videos that talk all about different behaviors with people with Alzheimer's disease. And so let me play this. I think we checked this out.
My mother's been waking up in the middle of the night and seeing things in her room that aren't actually there. We're both exhausted during the day because we're not getting enough sleep at night. Good night, Mom.
Honey, help me.
What's wrong, Mom?
There's an evil man in the room.
Mom, please. There's nobody here. No one's here. Go back to bed. Come on. Look, there's nobody here. All right? Go back to bed. You've got a big day tomorrow. Come on. Good night, Mom.
A person with dementia may experience hallucinations when the disease affects the regions of the brain that are responsible for interpreting sights and sounds. Hallucinations commonly involve seeing or hearing things that aren't there. They can transform ordinary, everyday experiences into frightening episodes. A good approach to reducing hallucinations is to identify and eliminate the objects or things that trigger them.
Honey, help me.
What's wrong, Mom?
There's an evil man in the room.
Oh, really? Let me take care of it. Come on. It's okay. Oh, I see. Okay, come on. Come on, I'll take care of it. Now you stay out here. Now he's gone, okay? I'll sit with you until you go to sleep, okay?
Okay.
You know, Mom, I think we should keep your coat rack outside so you have a place to keep your jackets when you come in.
Oh, okay, dear.
Okay? Okay. Good night.
Remember, patients experiencing hallucinations are having a difficult time interpreting their surroundings. Remain calm, reassuring, and try to identify what may be triggering the hallucinations. If hallucinations persist after trying to eliminate them, be sure to discuss this with their doctor. Here are a few tips on how to reduce hallucinations. Look around and try to see things through her eyes. What might cause her to misinterpret what she sees? Identify potential triggers such as open curtains, shadows, mirrors, or televisions left on. In the bedroom, use a nightlight to create a more peaceful sleeping environment. Always remember to remain calm and reassuring. Do not yell or scold her. Help her back into bed and reassure her that she is safe.
Here, hold on a second. So those videos, again, I think they're, again, dramatizations, understand that. But also just the world of having the understanding, again, to take the steps back and to see what a person with dementia might be experiencing. And when you're in a day program too, you say, yes, obviously this is a nighttime focused example, but realizing that their perception is going to be different. What they have, what they see and how they experience things is different than what we would process. So always, again, taking your steps back a little bit to be able to look and to be able to help your participants. So delusions are false beliefs that seem real to the person who is experiencing them. Let's say, for example, the person may believe they're on a cruise ship instead of at a day center. And you know what? That's fine. It doesn't matter. If the sky is purple, great. It's a beautiful shade of purple today. Again, why does it matter? So finding the things like there's no need to correct on some of these delusions. Again, hallucinations, we want to reassure safety, but delusions, they're very real to the individual. So there's no need for us to intervene. So again, never argue with the person. If it's not upsetting anyone, ignore it. So as one of the keys that you will learn is that you are the one that can change your mood and change your behavior and adapt. They cannot. So find the ways that you reassure them that they are safe. And again, redirect music, other engagement activities, or maybe this is when you find time for that quiet room where a person can just have a few minutes to be quiet and soothed. So wandering. So this is a question here that was in the chat. Let me know if I do not address your or do not get to your answer. So 6 in 10 people with dementia will wander at one point. And the number of families I've worked with in the past to say, oh, no, my loved one, they're not going to wander. No, they're never going to wander. One day I got an email from a support group member entitled, "They don't wander until." Her husband had wandered out of the house. Luckily, he was found in the neighborhood short time after. But he never was going to wander. No. He would never leave her side. He shadowed her. He was around her all the time. He wandered. So, how can we reduce the risk of wandering? Providing structured activities. This is where it really comes, and the role of a day program is very important for the families at home. Also, try to remove items that represent traveling or going somewhere. So if there are keys by the front door, if you're at home, there's obviously going to be more of a sign, this is where we exit. So the question in the chat was like, how do we support wandering? We can't have restricted practices such as locked doors, obviously fire reasons, and it's challenging. Of course, it's very challenging. But it's also the role of the day program to maybe reduce those ratios a little bit. You have a person whose job, while they're still engaging with people on the floor, they're always by the door. That's sort of like their station or their area. There's also things now where you disguise the door. You don't make the door look like a door. You can buy all sorts of things now. You can even make a door look like a bookshelf. It's just like not a shower curtain, get them on Amazon, like just like a fabric sheet that looks like something else. Maybe putting that near the door. Finding these ways to make sure the activities are never facing the door. You want to put their focus elsewhere. So the door is behind them or maybe even off to the side. So seeing how can you restructure the room that the participants are in. And I can't remodel, but how can we change these things? And it's just so crucial though, that like, especially at beginning stages, when a person first comes to a day program, how can you best support them and let them know, again, they are safe. There is a need behind that desire to wander. Do you have a staff person who could walk with them? Volunteers, find volunteers, see if they can walk with them. Finding these different elements, because sometimes when it's a ratio issue, that's a hiring issue, which is a funding issue, which is all these things. Find ways that you can get volunteers and bring people in who could help prevent the wandering, who can help support the participants and make sure that they are safe. I have another video here, but I'm not going to show it just due to time. But again, this UCLA Alzheimer's and Dementia Care videos are really great. They have a whole series of them on different subjects. So I highly recommend you go there and to watch their videos on your free time. So how do we prevent unwanted behaviors? Finding activities that a person enjoys, finds something that they can do as well. Make sure that it is appropriate for them and for their for their ability and their capacity levels. Don't argue. If something doesn't work, find something else. Try to redirect, always reassure. Also, always offer snacks. People love snacks, right? oh, we can't do that right now, but let's go get some juice. Let's go have some water. Let's go have some strawberries. Try to provide healthy snacks, but sometimes you need to provide a cookie because nothing else will. So finding these ways to help, again, reassure someone, calm them down, talk to the families to get this vital piece of information. Find a spot away from the noise or the confusion. Find a way that you are able to drop a level down. Again, day programs, your whole goal is that people are engaged in, high energy, but there has to be quiet time. Because if you are in something and you are fully engaged for 6 hours, you're going to be tired. And then you most likely will have some of these unwanted behaviors. And this is just you, right? This is even a person without any sort of cognitive challenges. When a person can't be redirected, because you can't always do it, wait until later. Sometimes it doesn't have to be done right now. Step away. See if someone else is available, because sometimes it could be a personality, right? Maybe they just don't like you today. That's fine. We all have days where we don't like people. So maybe you're not the best person to be the one providing the intervention at that point. Maybe it's, the HR director of the day center who this person loves for some reason. Call them up. Say, hey, I really need you. Can you step out for a minute? So-and-so needs some help. Again, when you're at a day program, you have all of these different people who work there. So it's not just about the people on the floor. That might be the ideal and what the basic plan is, but we need other backup and assistance. And also, again, looking at validation, letting a person know that you understand them and that you can be trusted. We want to, again, focus back on person-centered behavior, compassionate communication, these key elements of dementia care. This is really a way that will help reduce some of these behaviors. Your next presentation, the one next week, is going to really focus on this. But I just wanted to sort of give the light tease here to make the tie-in, is finding these ways for the different activities for moderate dementia. Cognitive, physical, social, emotional, expressive, creative. So it's not just a one size fits all. And seeing how all of these different elements are really important to be able to help with engagement and redirection. And then, so again, just in summary, I know I'm at time here. Remember that all behavior has a purpose. Behaviors can be triggered. So, who's around, what happened at the time of the behaviors, really put on that detective hat of yours. We can't change the person, but we could try to determine the unmet needs, and we can be the ones that accommodate those changes. Again, we're the ones that can respond to behavioral symptoms, and you have to be flexible. You have to be patient. You have to. That is the true requirement here, is realizing that it goes beyond just what we may want to do and what might be easy. Mid-stage dementia is difficult. It is a challenge for everybody, but also you have to remember the challenge that it is for the person as well who is living with the dementia. So thank you so much for your time. Thank you for being here. If you have questions, I know we're at time, but just want to be able to be open and available in case anyone has any questions. So again, thank you so much for listening.
Thanks, Monica. And while we're waiting to see if we have questions, I am going to stop sharing your screen, or have you stop sharing it. I've got a final slide to put up, and I'm also going to launch our final poll for the afternoon here. Let me get the last screen up here.
Oh, Kathy, I think you're trying to talk, but you're muted.
Just wondered while you were doing that, Catherine, if you wanted Monica to go back to the Q&A to the 2 questions. I know you did address wandering, but
That
so
is
great. So Monica, while they're doing the test, go ahead to those 2 questions.
Great. I was actually trying to type it out, so I can talk it a lot easier than I can type it.
Easier. Yeah.
So yes, so the first question is regarding, are there scans being done to diagnostically determine brain decay or some formations that could suggest dementia. Yes, absolutely. So an MRI can determine if there has been atrophy in the brain. It's not going to identify the plaques and tangles of the hallmarks of Alzheimer's, but it can identify if there has been any sort of degeneration. Especially, the MRI is especially good for people who may have frontal temporal dementia. So it's more the frontal lobe where there's greater areas of atrophy. So an MRI can work. Another type of scan is called a PET scan. And so a PET scan, though, they would inject a tracer that binds to the amyloid plaques in the brain. And then they're able to take a picture of the brain with the color from the contrast that shows the levels of amyloid plaque. So the PET scan doesn't show the atrophy, it shows the amyloid plaque based upon using this one tracer. So those are really the two versions of brain scans that are used for people with dementia to help again determine if it is what type of dementia it might be, because dementia itself is shown in clinical symptoms. So that's in the changes of thought, disorientation to time and place, words, language, memory, etc. And now we're looking at what is the cause of the dementia that is present in the clinical symptoms. Oh, I think I saw that in the chat. Hold on. Where did that go? Does Medicare cover those tests? It all depends upon your insurance. What plan do you have? What center or where is your medical care being taken at? So, well, how about this? We'll say yes with an asterisk, or yes, but. So that's all up to that.
And
Phyllis?
Monica, what about Medicaid or Medi-Cal, our Medi-Cal?
I think an MRI, and don't quote me, nobody quote me on this. But don't say Monica said. I think an MRI could be, a PET scan most likely not. But there has been over the past few years more, and I know this is Medicare, not Medicaid, but Medicare did a big study to see if it was worth it financially for Medicare to actually cover PET scans. It was a multi-year study, and it did show that it was. So that is something that is going to be more accessible for people. And again, that's Medicare, not Medicaid, but still realizing that if one public entity is looking that way, that hopefully another one, can as well. Kathy.
I want to add something most people don't know. Medicaid eligibility is not transferable, usually from county to county, or transferable from state to state. So if a northerner decides they want to go down to a southern state like Florida, where Abby, our presenter last month, it would not be automatically transferable, and there would have to be a readmission into the Medicaid program in Florida if that's where someone moves. So make sure that if you're making a move as caregivers grow older, that you investigate the eligibility for services to the state and county that you're going to.
Any other questions? I know I addressed the one regarding wandering during the presentation. So there's nothing else in the Q&A. So any other questions? Cool.
Liz, do you want to bring it to a close
No, I
then?
was just gonna-
Well, a close from the presentation part. I hope people will stay on and continue inputting the poll before they go off.
We'll leave
Yeah.
it up for a couple of minutes.
Okay, and we will close. I'd like to thank you all for your participation today. Monica, fabulous job. A lot of really useful information. We appreciate it. Next month, we'll be talking about failure-free programming in adult day centers for people with a dementia and or IDD. And we're hoping that you'll join us. It'll be the last Thursday of the month. And at this point, we'd like to say have a great day. Thank you for being here, and we'll see you soon.
Thanks, everybody. We'll see you next time. I'll leave the poll up for a couple more minutes, and the rest of us can just stop our videos and go about our day.
Bye, everybody. Thank you so much.